Okay. I think ጥሩ ነው። I think አሁን መጀመር እንችላለን። ስለተገኛችሁ እናመሰግናለን። አሁን ሌትሊ ጆይን ያደረጋችሁ ጥያቄ ካላችሁ ወይም ደግሞ የሆነ ሀሳብ ካላችሁ በቻት ላይ አስቀምጡ። እኔ ተመልሼ አንሚዩት አደርጋችኋለሁ ወይም ደግሞ እጃችሁን ሬዝ አድርጉ። ይሄ የእጅ ሬዝ በተን አለ አይደለ? ሪአክሽን ላይ እሱን ካሳያችሁኝ ተመልሼ አንሚዩት አደርጋችኋለሁ። ስለዚህ ዲስከሽን በዛ መልኩ ማስኬድ እንችላለን። ዋን ዌይ ሳይሆን ያው እንደ ምክክር አይነት ነገር ለማድረግ ነው የምናስበው እና በዛ መልኩ እንቀጥላለን። የተወሰኑ ፓወርፖይንቶች አሉን፣ እነሱን ሼር እናደርግና እንቀጥላለን ማለት ነው። ያው ድምፄ ከጎረነነ ያው ብዙ ቡና ገና አልጠጣውም፣ ጠዋት መነሳቴ ነው። Okay, so thank you very much for coming today to discuss on evidence-based physiotherapy practice. This is part of the continuous professional development module, I think, even though this is not very official. Hopefully, we will continue this discussion moving forward because evidence-based practice is really critical as practitioners and clinicians in any country, in any clinical and health settings. So just to brainstorm, you can write whatever you like in the chat. What is evidence to you? And what source do you use to access valid information? How do you know that your treatment approach is evidence-based? When do you say that your management is working for patients? So if you can put anything in the chat, I'll be happy, and then I will read that out loud for everyone. ከቻላችሁ ቻት ውስጥ ብታስቀምጡ ደስ ይለኛል አንዳንድ ነገሮች። ካልሆነ ደግሞ እዚህ ፖይንቶች እነኚህን ፖይንቶች ላይ ሪፍሌክት ማድረግ የሚፈልግ ካለ እጃችሁን አውጡና አንሚዩት አደርጋችኋለሁ if you want to reflect, just to make sure that we know that you have a lot of wisdom and also experience in this aspect. So share የምታደርጉን ነገር ካለ, if you would like to reflect on any of these questions. Okay, PubMed refer ማድረግ ብሩክ ሌሎቻችሁስ? Any reactions to these questions?
Sisai raised his hand.
Okay, unmute ላድርገው ታዲያ። Okay, ራሱ unmute ማድረግ መውጣት አለብኝ መሰለኝ ከዚህ። Stop sharing. Okay. Okay, Sisai?
So I think ከውጭ እየገባው ነበርና በስልኬ ተጠቀም ስለነበረ አሁን ቢደርሻለሁ። Just the evidence-based practice, it have 3 components, like መጀመሪያ the best available evidence ምንለው in different aspect የምናገኘው the best available evidence including the research and professional expertise, knowledge, experience. Second part ሲሆን የpatient preference and the patient value incorporate የሚያደርግ ዘርፍ ነው። So we will not just only referring the evidence, cannot make the intervention evidence based. ስለዚህ የpatient preference, patient value, concern of the treatment መካተት አለበት, and the experience of the individual or the professional or the expertise ያጣመረ integrated የሆነ service we can call it evidence-based practice.
Yeah, I completely agree with you. It's a perfect description of evidence-based practice. I think you kind of brought all of those components together to make sure that the care that we provide is meaningful for the patients. It's based on patients' values, patient clinician experience, and also based on evidences that's out there. Dechasa also said, I think Brooke, let me go back, as evidence. We kind of use meta-analysis and RCT studies. I think that's also great. Obviously, these are higher level of evidences. Dechasa said evidence is a scientific-based input used to persuade the existing, to verify or refute kind of care, I think. So to make new updates. I think that's also great, because that actually shows that we need to be evidence-based, and we need to follow the current trends. So I know you have a lot of say here, and happy to take any of your comments and read it out loud to the participants. If you'd like to, again, like unmute yourself, unmute እንኳን ማድረግ የምትችሉ አይመስለኝም. I think አሁን አድርጌያችኋለሁ, ግን if you would like to speak, please do so. Okay. Let's go to the next slide. So, as you know, obviously, like physiotherapy is an evolving science and practice. And if you think of history of physiotherapy a long time ago, I think we are not very sure when physiotherapy started. It might have started as massage or any other traditional therapies, but here we are today in 2023. We are really evolving with the profession, and the way we think of the profession. Physiotherapist's place in the health system, in research, in education is really growing from time to time. Even in our time, like in Ethiopia, many things changed since I graduated, for example, in 2008 European calendar. So many things are changing, but I was surprised to show you these pictures. This
sorry, you are not sharing your screen.
Sorry?
You are not sharing your screen. Please share your screen.
Oh, sorry. Okay. Share now. አሁን ሼር አድርጌያለሁ።
Yes, Mulay.
Perfect. All right, so I was obviously talking about evolution, and then these are some of the pictures I was so surprised to see. These pictures were taken during, I think, the First World War, and these are French navies or French armies, and you can see that even that time there was a provision of hot air therapy for patients. I think those must be those must be wounded or might have some injuries, obviously, because of war. And then this is an active movement therapy. You can see that this is a very smart way of moving patients. And I think this must be a therapist anyway, and you can see how they were creative to help patients exercise and mobilize their limbs. And they must be very genius anyway, right? And then electrotherapy. You can see how the electrotherapy machines were mounted on the walls, and then how that was provided to patients. And you can think this actually existed years and years ago, decades ago, and must be over a century if you think about those things. And we are still using them. And we need to we need to ask ourselves, like, what's changed since then? How has it changed? How are we helping our patients? And then we start thinking about, obviously, other modalities like mobilization, and then electrotherapy has changed so much from this picture to this. This must be ultrasound. and then activity or movement therapy, as you can see. Now you can see what is changed, what is the difference between this therapist and this therapist, difference of thoughts. And then we are still moving forward, and we don't know what happens 5 years from now, 10 years from now, 10, 20 years from now. But still we know that we are evolving as a profession, right? And then our thoughts and our care for patients must also evolve that way. So the evolution looks like that. For example, from a very traditional practice, which primarily focused on conventional wisdom, right? Like if you go to a traditional healer in a rural area, they have conventional wisdom. They never had any experience of receiving education, or maybe they don't know whether it's based on evidence or not. They don't have any data. Perhaps they may have some qualitative data from their patients, right? Like they would say, oh, I helped this person and the pain went away. And so, you know, we evolved from conventional wisdom into expert opinion, because we know, oh, you know, you have to visit this professional because, you know, he's expert report. I think unmute ማድረግ የምትችሉ ከሆነ ራሳችሁን አንሚዩት አድርጉ። ድምጻችሁ የሚረብሽ ሰዎች አላችሁ ፕሊዝ።
ሙሌ ንጋቱና ማይክ መሰሉኝ፣ የእነሱ ማይክ ነው ሲጮህ የነበረው።
ኦኬ፣ እኔ ማየት አልችልም። ሁሉንም ደግሞ ሚዩት ካረኩኝ ድጋሚ ያው ኮንቨርስ ማድረግ አንችልም። ሶ አይ ዶንት ኖ ዋት ኢቨር ሌትስ ሲ።
ንጋቱ ነው። ንጋቱ ፕሊስ ሚዩት አድርገው።
ኦኬ፣
ኧረ የኔ ባካችሁ ሚዩትድ ነው የኔ።
Okay, let me mute all of you then, and then ስትፈልጉ እጃችሁን አውጡና ተመልሰን እንትን ማለት እንችላለን። Okay. All right, so again, we said, you know, conventional wisdom, expert opinion, principles of anatomy and physiology. Now, if you, as a physio, obviously you understand physiology and anatomy, and then we base our assumptions of care based on that. Say, if there is contracture, there is there is deformity, that means we need to provide stretching. If there is cut, there is wound, maybe there is pain, and now there is understanding of anatomy and physiology, and then we kind of evolved into doing research, empirical data, and this is considered as traditional practice, right? Like we evolved from there to somehow a very complex care, where our clinical decisions are based on evidence, and that means, you know, the way we provide diagnose patients and provide management for patients, that has actually included your expertise, and it's backed by strong scientific evidence, and then based on patients' values and preferences at the center. Sisai has said earlier and talked extensively about patients' values, right? Like we understand that patients' values are very important in evidence-based practice. So there are a lot of different ways of looking at evidence-based practice, and there could be many definitions, but this is a definition from 1996. You can see it's an old definition. Perhaps one of the, you know, I think well studied definition of evidence-based practice. It's the integration of best research evidence with clinical expertise and patient values. And so if this is true, there are some limitations to this. I think especially when you think of the everyday care that you provide in your setup, especially in our own context, where patients, you know, care is determined by many different factors. So there are thinking about ethical principles of care, which, for example, one is autonomy, which reflects patients' respect for individuals, right? Like when you have patients coming to your clinic or your OPD, the first thing that we do is like respect them as individuals. So when you respect them as individuals, I want you to imagine or think about two different patients. If you have two different patients coming at the same time, say for example, someone with a higher status, and then someone from rural area, maybe someone who is homeless and on a street, I know as a provider, you would treat them equally because it's true. But is it really true that we provide the same, we kind of give them the same autonomy to decide on their care, right? These are some of the questions that we need to ask ourselves. Again, no harm, non-maleficence. These are also some of the guiding principles of care. And then we have beneficence. Here is where we should ask ourselves a lot of different questions. Is it really benefiting whatever I'm doing now as a therapist? Am I benefiting the patients? Is my approach beneficial to the patients? And then we kind of go to justice, and we talk about, is my care fair and equitable to everyone? So when we take all of this context, autonomy, non-maleficence, beneficence, and also justice into a pot and funnel that down, and then again add evidence-based practice into the context, then it becomes very, very complex. So it's not just straightforward. You download some articles from maybe PubMed, and then you read them, you understand the evidence behind that, and then you kind of translate that into practice. It also actually gets challenging as we go into the day-to-day care for patients. አሁንም እጃችሁን ማየት ስለማልችል, please, if you have any questions and reflections, you can stop me, and now I'll unmute you, and you can speak to this. Okay. So, and you know that, we talked about patient values, and what do we really mean by patient's values? So are we really respecting patients' values and preferences in our care? And how do you know that you've included patients' values and preferences? It's a very important question to address. And we know that illness is a biological, psychological, and social process. And then I would like to highlight more on the psychological and social process, because these concepts and constructs are less explored as physios. Like we are very much competent, I would say, to provide a lot of interventions that are very biological. And we need to do a lot, maybe because we haven't been trained enough to provide care which requires psychological and social aspects of care. So, and then this is where it gets complicated, evidence-based practice, because like I said earlier, it's not just simply having the expertise and experience of care, providing care. It's not only about understanding data and research. It's not only about taking patients' context into the care, but what about the larger environment? What about the larger social environment that you have to consider? And then it comes down to the clinician to decide, and also to provide care that is based on his absolute or her absolute judgment. And so we need to, I think, acknowledge the social and cultural determinants of health in thinking of providing evidence-based care. So maybe Ziga, just for 1 minute, could you think of any example that you can provide of the social and cultural determinants of health that could influence your patient's preference and values of care in your practice? Happy to, I think, discuss on this if you'd like to. Anyone? የመጨረሻውን point? Let's talk about those things. Unmute ላድርግና anyone interested? What are the social and cultural determinants of health? ምሳሌ ትበሉ ሄዳችሁ እንዳይሆን እያየኋችሁ ስላለ ነው።
አለን ፎሎ እያደረግን ነው።
አይ ነው ያ የቤተልሔም እጃቼ ነበር። anyone ይሄ የሶሻል እና ካልቸራል ዲተርሚናንትስ ኦፍ ሄልዝ የሚባሉትን could you give me some examples? Okay, I think in the interest of time, because we don't have a lot of time, you know them, I know, but just to give a quick example, we can think of our cultural practices, religion, for example, spirituality, and traditions, and how people live together, and all of that. Actually, many of them influence the way we that influences patients' preference, right? And so I think it's important to bring those things into context. And I remember I always share this with everyone who I talk to. When I was doing my research, Andwa Participante, she was a young patient with low back pain. And so, I asked her a lot of different questions, and she didn't think low back pain is really bad. And now she was a very spiritual person, and knowledge during the course of this back pain time, she had to visit monasteries, and she had to go to Tzabal, and she has seen many different places, and she thinks that it's ይሄ pain የእግዚአብሔር ጸጋ ነው because እንደዚህ አይነት ቦታዎችን እንዳይ ያርጎኛል ነው ያለችው። እና that perspective, as a clinician, that's a very different perspective compared to someone who is say catastrophizing pain, right? And so ይሄ ሁሉ ማተር ያደርጋል in terms of how you provide care to your patients, and then in terms of the evidence-based practice as well. So እንደገና ሪሼር ላድርግ። So I think Zelalem will talk a lot about these steps. You know that you have to start somewhere else. You need to formulate a clinical question, convert that to a searchable format, which Zelalem will talk about. And then we have to do literature search, critical appraisal. We need to apply that on patients, and then reevaluate the steps moving forward. And that is how we say that we are evidence-based practitioners. There are fundamental tenets of evidence-based practice. One is obviously the awareness of best available evidence is required for best decision-making. And I think I have to say, how many of you, I know, graduate how many of you really have gone to these places to look for evidence? And know that evidence-based practice helps us to understand how trustworthy evidence is. And then we need to understand that there is hierarchy of evidences. Not all evidences are the same. Not all evidences are equal. And so trying to look at hierarchy is important. Brooke said earlier, meta-analysis and also randomized controlled trials, which are at the top of the pyramid compared to opinions. And then, as we said earlier, evidence on its own is never sufficient to make clinical decisions. And so that's where your expertise and then patients' values come into context. And you might have seen this kind of pyramid before. And on top of the ladder, you can see systematic reviews, and then critically appraised evidences, and then articles, individual articles, synthesize የተደረጉ ኤቪደንሶች ይኖራሉ። የተወሰኑ አርቲክሎችን ሰብስበን አንዱን አርቲክል ደግሞ ክሪቲካሊ አፕሬዝ ልናደርግ እንችላለን። and then randomized control trial ይመጣል። ከዛ ኮሆርት ስተዲዎች አሉ፣ የፎሎ አፕ ስተዲዎች ይኖራሉ፣ ኬስ ኮንትሮል የምንላቸው ሪፖርቶች ይኖራሉ። ከዛ በኋላ ባክግራውንድ ኢንፎርሜሽን such as opinion and many different things ይመጣሉ። you see, these are filtered information, these are unfiltered information down here. So quality of evidence በዛው ይመሰረታል ማለት ነው። and I know you know these things. So here is a question for you. So if your patient, say this is your story, my patient is presented with mechanical neck pain, what is effective management? Would you prefer mobilization or exercise for this patient? I want you to think about this just for a second. Reflect ማድረግ ከፈለጋችሁም reflect ማድረግ ትችላላችሁ። Okay, Michael said, when we think about evidence-based practice, does that necessarily mean we abandon conventional approaches? This is a very interesting question. I don't think we have to abandon conventional approaches. We only look at conventional approaches from using a different lens by bringing evidence into it. Does it work or not? And then we ask ourselves, is it really working? How do I know that it's working? Other than that, I think we have to cultivate conventional wisdom in approaches. And evidence-based practice is not against conventional approaches, but it actually strengthens conventional approaches, because conventional approaches are based on our expertise and our knowledge. So yeah, happy to discuss on this as well, but this is my initial reaction. Okay, so like I said, mechanical neck pain ያላት patient መታለች. Would you choose exercise therapy or mobilization? Think of this in your day-to-day practice. So here is a research from 2015. So effectiveness of mobilization therapy and exercise in mechanical neck pain. So this is just a summary of the article. So the objective was to compare the effectiveness of Maitland and Mulligan mobilization and exercise among people with neck pain. ስለዚህ የሜትላንድ አፕሮች አለ፣ የሙሊጋን አፕሮች አለ፣ ከዛ ደግሞ ኤክሰርሳይዝ። ስለዚህ ይሄንን ኮምባይን በማድረግ የትኛው ነው ሞር ኢፌክቲቭ የሚለውን ሜተድ ለማየት ነው ያሰቡት። They've included 60 people with pain lasting less than 12 weeks, which is kind of acute pain or semi-acute pain. And then group 1 received Maitland mobilization and exercise. Group 2 received Mulligan mobilization and exercise. Group 3 received only exercise. And then there was a blind assessor. The researcher and the providers are different. And then the result is as follows. Pain got better over time. I want to underscore this. Pain got better over time. Gradually, pain በጊዜ ሂደት ተሻላቸው. And then there is statistically significant result. However, there was no significant difference between the groups. ያ ማለት ሜትላንድ እና ኤክሰርሳይዝ የወሰዱ ግሩፕ እና በሙሊጋን እና ኤክሰርሳይዝ የወሰዱ ግሩፕ and exercise ብቻ የወሰዱ ሰዎች መሃል ምንም ዲፈረንስ የለም። This is what the evidence is showing. There is no difference. In that case, then how do you reconceptualize your care process, right? So when nobody is saying Maitland exercise mobilization does not work, nobody is saying focus on exercise, nobody is saying Mulligan is better than Maitland, but research is showing that over time, there is no difference between these three groups. So no group was superior to another after treatment and follow-up. The conclusion is that manual intervention were no better than supervised exercises in reducing pain, improving range of motion, and neck disability. So, say if for me, if I'm a clinician working in a, for example, Ethiopian setting, so I would say I have a patient from countryside. Can I see him for one session and send him back home with exercise versus asking him to wait maybe 2 weeks or 3 weeks of mobilization? So it's kind of like a question to ask ourselves, but I'm not here to judge anything different. So ሌላው እዚህ ጋር ማሰብ የፈለግነው ምንድነው ኢፌክት ሳይዝ እና ሚኒማል ክሊኒካሊ ኢምፖርታንት ዲፍረንስ የምንላቸው ነገሮች አሉ። ኢፌክት ሳይዝ are a statistical calculation used to compare the efficacy of different agents by quantifying the size of the difference between treatments. Effect size የምንለው ማለት ነው. And I remember a couple of years ago, I always share this story. When I was working at the University of Gondar, የሆነ ፔሸንት ይመጣል እና ተማሪዎች እያስተማርኩ እኔ ቁጭ ብያለሁ ቢሮ እና የሆነች ፔሸንት ትመጣለች ታማ እና ለሁለት ነው ተሸክማት የመጡ እና ፔሸንቷ ለተወሰነ ሳምንታት ከአልጋ ላይ መውረድ አልቻለችም because of pain or I don't know what went wrong. እና ተማሪዎቹ አሰስ እያደረጓት they couldn't find anything. It's hard to reach on diagnosis. እና ጠርቶኝ ሄጄ ፔሸንቷን ሳናግራት ፔሸንቷ I saw a lot of psychological markers on the patient. For example, አልጋ ላይ መቀመጥ አትፈልግም. she would say እወድቃለሁ ነው የምትለው እና ፍራሽ ላይ ያስቀምጡኝ ትላለች። እሺ ፍራሽ ላይም እኔ ኬር ጊቨሮች አሉና ደግፈን እናስቀምጥሽ ስንላት የሆነ የመፍራት ስሜት ነበራት እና immediately yes okay there is some psychological element into this problem ብዬ understand አደረኩና just because I talked to her, just because I really encouraged her and we supported her, ስትሄድ በራሷ ነው የወጣችው እና it was like a miracle to me. I didn't do anything for her. Can I claim that my approach was better? Can I say that I have provided effective treatment for this patient? This is a big question to ask, but I don't have any answer. So sometimes we take a lot of credits as clinicians for the care that we've provided, but we are not sure whether it helped them or not. So this is where effect size and clinically important difference comes into play. So effect size is a measure of the difference in outcome under 2 or more different treatment interventions, such as, for example, Mulligan versus exercise. So statistically difference all the way between groups and it indicates whether the difference observed between the 2 treatments is clinically relevant and meaningful in real world. And then the larger effect size, the better in terms of that. So here is a kind of hypothetical example. Say, you have an overweight people aiming to lose weight. And then there are 2 groups in the experiment, in the trial. Experiment 1 or experimental group, they received diet and exercise. Control group they received only diet. Just ምግብን ብቻ maybe modify በማድረግ ማለት ነው. After 6 months, the mean weight loss for experimental group was 10 kg. 10.6 ኪሎግራም ሉዝ አደረጉ እና ሪዛልቱ ስታቲስቲካሊ ሲግኒፊካንት ነው። የኮንትሮል ግሩፑ ደግሞ 10.4 kg ሉዝ አደረጉ still statistically significant ነው። ሁለቱም ግሩፖች ሉዝ አድርጓል weight። ግን is it clinically meaningful? Is it really relevant? ብለን ስናስብ of course ለምሳሌ የኤክሰርሳይዝ እና ዳይት ኢንተርቬንሽን የወሰዱት በ0.2 kg በልጠዋል ምክንያቱም እነሱ more weight lose አድርጓል። So what does this mean for a patient? If you tell the patient that after 6 months you will lose 10.6 kg with diet and exercise, but you will lose only 10.4 kg just by modifying your diet. Which one do you think the patient would choose? ስለዚህ ለምንድን ነው ኤክሰርሳይዝ ታዲያ በየቀኑ የምሮጠው ሊል ይችላል። ስለዚህ everything we do we have to see it with a different eye ማለት ነው. So again, we cannot say that only 0.2 kg between the groups is significant and meaningful in care. The same is true for other physiotherapy approaches as well. So how can we build physiotherapy practice on evidence? And I think continuous professional development for practicing physiotherapy is important. And we need to make sure that our physiotherapists are encouraged to be involved in research, clinician researchers, and then knowledge translation processes. And then we need to promote the use of evidence at all levels, system, and forms of healthcare in Ethiopia. Yeah, ለሌላው discussion time ለመስጠት ነው. And we know the WCPT says that physical therapists have a responsibility to ensure that the management of patients, clients, carers, and communities is based on the best available evidence. They also have a responsibility not to use techniques and technologies that have been shown to be ineffective or unsafe. So I want you to ask yourself, what is an ineffective or unsafe approach that I have been using, perhaps in my clinical setting? Again, we need to see that evidence should be integrated with clinical experience, taking into consideration beliefs, values, and the cultural context of local environment, as well as patients' preferences. Again, evidence-based practice is more easily achievable in environment that embrace and promote evidence-based practice. Finally, for example, Canadian Physiotherapy Association, they also have a say in the evidence-based practice arena. They say that physiotherapists are responsible for keeping up to date with current research findings that support physiotherapy treatment interventions, and for integrating this information with clinical expertise, patient values, and available resources to positively impact the health of Canadians. So same is true. We need to ask ourselves, how do we promote evidence-based practice in Ethiopia? And then this is part of it, Marathon. So just want to say thank you. And if you have any questions, discuss ማድረግ እንችላለን, but I will leave the floor to Zelalem to talk about the next processes. ጥያቄ ካላችሁ I think መቀበል የምንችል ይመስለኛል፣ ግን anyway we can
ወይ መጨረሻ ላይ ማድረግ እንችላለን።
All right, Zelalem.
Okay, thank you so much, ሙሌ። ስለዚህ እኔ ማውራት የፈለኩት የተወሰነ መጀመሪያ ሙሌ ያወራቸውን ነገሮች ስትረስ ለማድረግ ነው። Why do we need evidence-based practice የሚለውን, and then we'll talk about the steps. So this is a quote from Iona Novak. She's one of the professors in pediatrics rehabilitation, and she said that the most difficult thing we can do as therapists is to be up to date. And it's really, if we are not up to date, if we are not evidence-based practitioners, we are not being ethical, and this is critical. So I'm going to share an article that I recently found, which is really, really interesting. So it's about why do ineffective treatments seem helpful. So I'm going to, so ምንድነው መሰላችሁ እዚህ ጋር ጀነራሊ የዚህ ስተዲ እዚህ ላይ የሚጠቅሰው ሰከንድ ብዙ ጊዜ ክሊኒካል ፕራክቲስ ላይ ሰዎች ይመጣሉ፣ እኛ ጋር እናክማቸዋለን፣ we treat them። ከዛ በኋላ they get better አይደል? ስለዚህ ከተሻላቸው በኋላ ምንድነው የምናደርገው? ክሌም ነው የኔ የሰጠኋቸው እኛ የሰጠናቸው ኢንተርቬንሽን is effective because the patient got better ብለን ኮንክሉድ እናደርጋለን። ግን ምንድነው this is not right የሚለውን ለማሳየት ነው። ለምሳሌ let me go to this one. So after a therapy, when symptoms improve, healthcare providers are tempted to award credit to the treatment. However, practitioners accumulated day-to-day informal impressions of diagnostic reliability and clinical efficiency are of limited value. It's not reliable. እኛ ራሳችን የምናየው ይሄ ትሪትመንት ኢዝ ኢፌክቲቭ ምክንያቱም ፔሸንቱ ተሽሎታል ከዚህ ትሪትመንት በኋላ የምንለው ኢዝ ናት ሪሊ ሪላያብል አይደለም ማለት ነው። ምክንያቱም between the initiation of therapy and any follow-up and assessment, real measurable improvement of symptom often occurs. ለምን ይመስላችኋል? ምክንያቱም አንዳንዴ ኢፌክቲቭ ትሪትመንት የወሰዱት ፔሸንቶቹ they get better. Why do you think? Why do you think they get better? Maybe I will ask Mule. So we know that the treatment is, for example, is without an effect, but the patients get better. And why do you think? Why is it? What could be the reason?
I think everybody has their own experience, and to me, like I said, when I now reflecting, I would say that maybe it's placebo itself, right? Maybe it's because of bias. Maybe it's because sometimes when we see healthcare providers, our pain get better, right? Like there are many different in action, but there is also physiological things that can happen immediately after the care. So we don't know which one worked anyway.
So really to know treatment's effectiveness, we have to go back to the evidence. It's only randomized controlled trial or researches that show the effectiveness of treatments. For example, one of the causes could be natural history of the disease. Right? Over time, a disease that naturally comes and go may even provide patients and practitioner with numerous opportunities to assume erroneously that the treatment has been effective. አንዳንዴ በሽታዎች በራሳቸው ይድናሉ። there is natural history of disease የምንለው አለ። እሱ could be the placebo effect. It might not be the direct effect of the treatment, but it could be placebo effect. It could be ለምሳሌ አንዳንድ ጊዜ ፔሸንቶቹ በዛ ከአንድ ከቪዚት በኋላ ኢኒሺዬሽን ኤንድ ፍራስትሬሽን motivate patients to visit a particular healthcare provider may inspire other helpful actions. ለምሳሌ ሰዎች ሲታመሙ ቢሄቪየራቸውን ይቀይራሉ። more sleep, more exercise, less stress, other ከኛ ትሪትመንቶች። ስለዚህ that could be the reason እነሱ የተሻላቸው ሌሎች ህክምናዎች የነሱ ቢሄቪየራል ቼንጅ እነዚህ ሊሆኑ ይችላሉ። ኤንድ ኮንፈርሜሽን ባያዝ ብዙ ጊዜ ምንድነው ይሄ ኮንፈርሜሽን ባያዝ የምንለው ፔሸንቶቹ እኛ የምንፈልገውን ነገር ነው የሚነግሩን። ለምሳሌ አንዳንድ ጊዜ እንዴት ነው የምንጠይቀውም ሊዲንግ ኩዌስችን ነው አፍተር ትሪትመንት። ፎር ኤግዛምፕል we might say that are you getting better? So they say yes, even though that's not the right. ስለዚህ clinical outcomes are multifactorial. So really, clinical outcomes only measure the outcomes, not the effects of the interventions. It's really multifactorial. So experiments like RCT or controlled interventions that limit biases to isolate the effects of an intervention with a high degree of certainty. So clinical outcomes are always multifactorial. Because of this, we need to look at the research. So that's why we need to look at the research. So there is also another very interesting term that I found on the internet. So it says emotional-based practice. So emotional-based practice is utilized when evidence exists to refute the use of a specific test or intervention. In other words, a clinician has selected to use the test or intervention despite evidence to the contrary. ለምሳሌ አንዳንድ ጊዜ ክሊር የሆነ ኢንፌክቲቭ ትሪትመንት ነው። ለምሳሌ ኤቪደንስ የለው ያሳያል፣ ግን ስቲል ቴራፒስትስ ዩዝ ኢት። ምክንያቱም ምንድነው ኢሞሽናል አታችመንት ዴቨሎፕ ያደርጋሉ ከዛ እንትን ጋር፣ ወይም አንዳንዴ አይደንቲቲያቸውን ቤዝ ያደርጋሉ በዛ ኢንተርቬንሽን። ስለዚህ they don't want to change, they want to stick to that. It's being emotionally attached to the intervention. Again, we are not defined by the intervention that we provide, right? So let me give you one exercise. Think about your favorite intervention for a particular disorder. For example, I work with kids with cerebral palsy most of the time, and I have a particular favorite intervention. ማሰብ ትችላላችሁ እስቲ ስለ አንድ ዲስኦርደር ፌቨራይት የምትሉትን ኢንተርቬንሽን ያስቡን። ከዛ ለምሳሌ ነገ ይህን ኢንተርቬንሽን ክሊር የሆነ ኤቪደንስ ብንሰጥ አንድ ሰው ቢያቀርብላችሁ ይሄ ኤቪደንስ ይሄ ኢንተርቬንሽን ዳዝንት ወርክ ለዚህ ፖፑሌሽን የሚል ክሊር ኤቪደንስ ቢያቀርብላችሁ would you give it up? would you give it up? ያንን መስጠት ታቆማላችሁ? just think about it. ምክንያቱም ይሄንኛውን ኤክሰርሳይዝ they did it in students with graduate level physiotherapy students, and they found most of them say no, we will not. They will stick to their favorite treatment, even though there is really clear evidence that shows that it doesn't work. So, but I mean, we are a scientific profession. We should base our interventions and every action based on the evidence. So let me tell you about the 5 steps. I think you know all of them know about that. So we ask them to first, we formulate answerable clinical questions, and then we assess, we appraise, we apply, and then we also lastly evaluate the effectiveness of the process. So first, we assess the patients, right? So clinical question form እናደርጋለን መጀመሪያ። Then clinical question could be management option, anatomy ሊሆን ይችላል። ለምሳሌ ምን አይነት ቴስት ነው የምንጠቀመው ሊሆን ይችላል። ፋክተሩ ፕሪዲክት የሚያደርጉ የፊውቸር ሄልት ስታተስ፣ ቤኔፊት፣ ሪስክ ኤንድ ፖቴንሻል ኢንተርቬንሽንስ እነዚህም ሁሉንም ሊሆን ይችላል። ሰው ኩዌስችኖቹ ብዙ ጊዜ ምንድነው ኩዌስችን ፎርም ስናደርግ I think you know this, we use PICO, population intervention comparison and outcome. So P is person, the problem or the population. It's a very easy rule to use to formulate clinical questions. I is the issue. For example, it could be about the intervention. C is comparison. What is it compared to? And then O is the outcome. So let me give you, for example, one example. So is manual test reliable and valid measure for quadriceps strength in a 42-year-old woman with multiple sclerosis? For example, is manual test is reliable and valid as handheld dynamometer comparison for measuring quadriceps strength in 42-year-old woman with spinal cord injury? So ማንኛውንም ያላቸው ክሊኒካል የሚያጋጥማቸውን ኬዝ በዚህ በፒኮ ፎርማት ወደ ጥያቄ መቀየር ትችላላችሁ። ለምሳሌ this is a question about intervention. ለምሳሌ PNF is effective treatment technique for restoring core trunk stability in a 7-year-old child with right hip paralysis due to stroke. This is just a question about intervention. Then we go and search for evidence, right? So which sources are more credible? So there is scholarly course sites and also public informational data that's available. For example, information that we get on social media, on Google, those are not peer-reviewed, those are not scholarly. So usually to go to find evidence, you go for more scholarly approaches. So the second one is we search for the best available evidence. Then we track down the articles or the evidence ማለት ነው። ስለዚህ we search በኪወርዶችን በመጠቀም we search ማለት ነው። So let me give you some tips for selecting articles. Sometimes you can use these tips. ለምሳሌ write PDF and the title of the paper in Google. For example, if I want to take this one, reconceptualizing pain according to modern pain science, this is one article. So you just put PDF and then search it on Google, and you might be able to get it on Google Scholar, for example. You can search it on Google Scholar. Sometimes if the articles are not available for free, you can write email to the author. They usually respond. You can do that. ResearchGate is a very good platform. And ለምሳሌ ፐርሚት አክሰስ ያላቸው ካሉ ደግሞ ጓደኞቻችሁን ፍሬንዶቻችሁን ጠይቃችሁ ያን ፔፐር ማግኘት ትችላላችሁ። ይሄን ደግሞ አንድ ራሽን ሀገር ሳይት አለ ACCIHA.se የሚል so this is you can also use that especially in our setting. Second. So the second one is hierarchy of evidence, right? So after you search, every article is not the same, right? ቅድም ወደ እያላችሁ እንደነበሩ ለምሳሌ ሁሉም አይነት አርቲክሎች ተመሳሳይ ሌቭል የላቸውም። for example, the first level is if it is systematic review or meta-analysis is a combination of RCTs, randomized control trial. So if you want to know about effect of intervention, you should always go for a systematic review or meta-analysis. If that's not available, you go for RCTs, and then you go for control trials, cohort, descriptive, and the last one is expert opinion. So this is I think most of you know about this. Okay. So the next one is critical appraisal. You search it and you track down the best available evidence, and then you need to then appraise it. እንዴት ነው ያገኘሁት article? Is it good quality? ወይም weakness-ን strength-ን before you apply it to the patient, you have to check ማለት ነው። So ብዙ ጊዜ በክሊኒካል appraisal ስንል we mainly check three things: validity, applicability, and clinical importance are very important. For example, when you say validity, a valid piece of research truly measures that what it set out to measure. For example, to give valid results, a piece of research needs to have a clear objective, methodology, draw appropriate conclusions from the data. So these are characteristics of a valid research: clear objective, methodology to minimize bias, and they draw appropriate conclusions from the data, from the data that they found. So does the introduction clearly describe the objectives? For example, is there a methodology, study reporting, patient selection, bias? Different bias which are እነሱን ሚኒማይዝ ተደርጓሉ። patient selection ላይ reporting ላይ everything you check this, and then the authors draw conclusions that are supported by the data. So conclusion in these abstracts and discussion may be biased by the author's predetermined ideas about the results. You should ensure that the results and the conclusion are concordant. Have the authors discussed other work, or that both support and contradict their finding, or may have focused on one aspect only? So this is also very important to check. And then clinical importance. So that now you know that the results are valid and well reported. Are they clinically important? Statistical significance does not always equate to clinical significance. And then the last one is applicability. Does it apply to our context? Does it apply to your patient population? Milone, you have to check. For example, would your patient have been eligible for the clinical trial? Clinical trial corner, if it is in different population, it's a corner, another population, my whole corner, the result may not apply. If the characteristics of the patient that are included in the intervention that study different from your typical population. So, and also patient selection, you can also check that. So is the intervention available in your setting? The diagnostic technology, the intervention is available. Do you have the right training to carry out the intervention safely and effectively? You should also check, because if you don't have the right training, even if it's evidence-based and it works, you cannot apply it. So you have to check that. So ለምሳሌ setting, for example, if the intervention require a week-long inpatient stay, when this is not feasible in your institution, ለምሳሌ አንድ ሳምንት ምናምን ቆይቶ መሰራት ያለበት ኢንተርቬንሽን ከሆነ ፊዚብል ካልሆነ እናንተ ሴቲንግ ላይ ይህንን ማየት ኢንተርቬንሽኑን ኮንቴክስት ማየት ያስፈልጋል። then the next one የምንሰራው ምንድነው? you integrate this evidence with your own clinical expertise and patient preferences, with their value, unique biology, unique circumstances, and then you integrate it, and then lastly you evaluate our effectiveness and effectively in executing steps 1 to 4 and seeking ways to improve them both for next time. So it's an ongoing process. It's not one-time process, because evidence is changing. It's really a process that we have to follow and do all the time. So let me give you one really interesting method that they use now that evidence traffic light. So in systematic reviews, they classify interventions into three. Look in the traffic light and the source. So green line የሚያስቀምጧቸው interventions based on data, obviously, they are proven effective. So usually you are expected to use this type of interventions. And there are interventions that are categorized as yellow. So in uncertain, so there is insufficient evidence, could be no evidence, and conflicting evidence ይሆናል። So ምንድነው የምናደርገው? ሜዥር ኢፌክት እናደርጋለን፣ እንጠቀምባቸዋለን and then we use our judgment, clinical judgment. So there are other interventions that are proven ineffective. So you don't use these interventions and you choose another alternative. So for example, this is for cerebral palsy from one of the systematic reviews that was recently published in 2020. So let me show you, for example, here is for motor outcomes in children with cerebral palsy. They found out that constraint-induced movement therapy, bimanual, handwriting, co-op, these treatments approaches are effective. And for example, casting and all, they are in yellow. And for example, here, neurodevelopmental therapy for motor outcome in children with cerebral palsy is found to be ineffective. So don't do it. They classified it as an effective. And so choose other alternative because there are other alternative and good interventions. This is also from the same study. This is for contracture and alignment. So yeah. So just an interesting study. You can also find other similar studies in other topics, and you can also use it እናንተም ራሳችሁ እንደዚህ ይሄንን ማድረግ ትችላላችሁ። ዴቨሎፕ ማድረግ የትኛዎቹን ነው ፕሩቭን ኢፌክቲቭ ለዚህ ፖፑሌሽን ለዚህ ኮንዲሽን የሚለውን በዚህ መልኩ አይታችሁ ራሳችሁን ይሄንን ማድረግ ይቻላል፣ መስራት ይቻላል ማለት ነው። ቴንክ ዩ I think we can go for discussion.
Thank you, Zalalam. I'm sure this is a good context, but we understand that we would have loved it to be hands-on practice. ለምሳሌ እዛው የሆነ ፔፐር አፕሬዝ አድርገን ሌቭል ኦፍ ኤቪደንሱን ብናይ ደስ ይለናል፣ ግን ታይሙ አይፈቅድም for sure. But I think personally I believe that this is the first step to come together to talk about evidence-based practice. ከዛ በኋላ I'm sure የኢፒቲኤም I see Nuruddin here, and of course Brooke is here, and other members. So perhaps we suggest maybe to have like a community of practice where people can come voluntarily and discuss about evidence-based practice, appraise research and all of that. Anyway, so I think this is our presentation, and then we are happy to take some questions and maybe I think discuss on few unaddressed issues, maybe, or interesting issues, or if you would like to share your experience with us as well. So. ጥያቄ ካላችሁ ወይም ደግሞ ዲስከስ ማድረግ የምትፈልጉት ነገር ካለ please share that with us. I think while I believe personally that maybe this kind of trainings are good, I think it will be at the surface level, and we want it to go deeper. So how do we translate this into action? የተማርነውን ወይ ደግሞ ዲስከስ ያደረግነውን ወደ አክሽን መቀየር። I know it's challenging. Like, we are not naive. Personally, I know that it's really challenging to translate evidence into practice and to be always on top of evidences for many different reasons. Internet አንዱ ፕሮብለም ነው። obviously article ማግኘት፣ ሌሎች ነገሮች ኢሹዎች ይኖራሉ፣ ግን we need to strive for that as much as possible, but we need to work together as well. ከጎን ካለው ፊዚዮ ጋር በደንብ አብረን ለመስራት ዲስከስ በማድረግ እንደዚህ አይነት ነገሮችን ልንቀርፍ እንችላለን የሚል እንትን አለኝ። ግን anyway, so I'm going to stop talking, but please. Yes, ዳግማዊ። ይቆራረጥ ነበር። እስቲ አሁን ይሰማል። yes
ይሰማል። thank you የኔ ጥያቄ በጥያቄ like evidence based እና አሁን ከባዮሳይኮሶሻል ነው በአብዛኞቹ ትምህርቶቻችን የምናደርገው ሲባል ነው። ሌላ ጊዜ እሱ ላይ በደንብ እንዴት መስጠት አለብን ፕሮቫይድ ሌላ ጊዜ ማለት ነው ወስዳለን ብዬ ተስፋ አደርጋለሁ። ግን ጥያቄ አንዳንድ ኤቪደንስ እና ከካልቸራችን ጋር ሰዎች አሁን ባይኮሶሻል ሰፖርት ከሆነ አንድ ሰው መታሸት ተሻለ ብሎ ከሆነ ኤክስፔክቴሽኑ የሚመጣው ፊዚዮ ሲመጣ እንደ ኤግዛምፕል ነው ኤክሰርሳይዝ እናሰራዋለን ሳምቲንግ ሌሎች ነገሮችን እናደርጋለን። አንዳንድ ጊዜ ግን እንደ ቢዝነስም የማይጎዳው ከሆነ ያ ነገር የምንሰጠው አማራጭ ህክምናዎች የማይጎዳው ከሆነ ካልቸራሊ ብንሰጣቸውና ኮምባይን ብናደርጋቸው ሁሉም ነገር ኤቪደንስ ቅድም ማይክል አንስቶ ይባላል ኮንቬንሽናል ከራሳችን ኤክስፔሪንስ እና ሁለቱን ማጣመር አንችልም እንደ ጥያቄ።
I think this is an interesting question, ደግሞ relevantም plus ደግሞ sense የሚሰጥም ጥያቄ ነውና I'm not against any of those. I think it's only a realization. I think what we have said is just to realize that not everything we do is evidence-based. Not everything we do is helpful. And particularly, I think in terms of looking at outcomes. At some point, you know, what is our target? ለምሳሌ immediately patient to clinic ባለበት ጊዜ እኛ expect የምናደርጋቸው ነገሮች አሉ። The first thing, for example, I like as a physio, I would like the patient to feel better, no pain or less pain. It's a big gain. It's a very positive thing to hear, regardless of what I do for them. So you see what we said earlier is like, does it benefit the patient? And then you ask yourself, if I continue doing this, how will I improve patients' health and well-being over the long term, right? And there are different things that you can ask yourself, questions that you can ask yourself. And I personally believe that it has to be combined. And these days we talk about patient-centered care, obviously. Patient-centered care synil demo, we have to bring patients context into practice. Patient value, culture, understanding, and all of that. And then the next step for a physio is to provide pain education, right? Like we need to teach patients about the anatomy and physiology of pain. When I say this, I'm not saying like we need to talk about the anatomy, but at some point in a language that they understand, we need to educate them. And then through education, I think through working together with patients, we will be able to change their perceptions. The only problem is that if we provide the care and then we send them away, and then we know that they will come back tomorrow or maybe in a week time with the same problem, then that's the time that we need to say, okay, what is next? What kind of approach should I use? And now I think we need to combine those wisdoms. And it's not explored. We haven't done research in Ethiopia. How can we use cultural practices? How can we integrate cultural practice in modern care? Minimum research I think so I'm not here to say that it's not working, it shouldn't work. I think it has to be combined. But as a physio, we need to ask ourselves that, okay, is it working? የሚል ሪፍሌክሽን ያለኝ አይ ቲንክ ዘላለም የምትለው ነገር አለ ሌላ
እዚህ ጋር? አዎ፣ ምክንያቱም ቬሪ ኢንትረስቲንግ ኩዌስችን ዳጊ አንድ ያነሳኸው የማይጎዳቸው ከሆነ ስለዚህ ሀርምን እንዴት ነው ራሱ የምናየው የሚለውን በደንብ ማየት ያስፈልጋል። አንዳንድ ኢንተርቬንሽኖቹ ራሳቸው ሃርምፉል ላይሆኑ ይችላሉ። ነገር ግን ለምሳሌ ፔሸንቶቹ የሚያጠፉት ታይም እዛ ላይ የፔሸንቶቹ የሚያወጡት ገንዘብ እነዚህ ነገሮች ጉዳት ሊሆኑ ይችላሉ እና ለምሳሌ አንድ ቬሪ ኢንትረስቲንግ ስተዲ ነው የህፃናት ሴሬብራል ፖልሲ የሰሩት ከብዙ በኋላ ልጆቹ ካደጉ በኋላ ነው ኢንተርቪው ያደረጓቸው እና በፊት የነበራቸውን የሆነ ትሪትመንት ኤክስፒሪየንስ ነው እና ዘ ትሪትመንት ኢዝ ሪሊ ናት ዳት ማች ኢፌክቲቭ እና በኋላ ሲጠየቁ ምንድን ነው ያሉት ፔሸንቶቹ የዛ ጊዜ እዛ የምንመላለስበትን ሌላ ቦታ ለምሳሌ ትምህርት ቤት ብንሄድ ኖሮ ከጓደኞቻችን ጋር ብንጫወት ያን ብናደርግ ኖሮ የበለጠ ለአዳልትሁድ ቤኔፊሻል ይሆን ነበረ የዛ ብናጥፈው ጊዜ ኢዝ ናት ወርዝ ኢት ያሉት አለ። ስለዚህ ሀርም ኢፌክቱ የትሪትመንቱ ኢፌክት ብቻ ላይሆን ይችላል እና ሌሎች ነገሮችንም ማየት ኮንሲደር ማድረግ ያስፈልጋል። ታይም መኒ ምናምን የሚለውን ያልፏቸው።
So the other thing that I would like to add here, I think maybe that we haven't done, maybe considered in Ethiopia, is there is something called quadruple aim or triple aim concept these days in patient care. One is obviously patient experience. Yeah, patient experience is very important. It's pillar to any care. So the patient value, preference, needs, exhaust integrate right? The other piece is also the clinician's expertise and also experience, right? And the clinician, are we competent enough to provide care? Are we even safe to provide those cares? Not just simply providing safe care, but are we even safe for the patients? Is the environment comfortable for a physio or a clinician to provide that kind of care? Is the environment supportive? Because most of the equity in as well, because cost is so important, right? Like we need to make sure that for every birr the patient pays, we provide them equal or even better care. Yanin b'masab, no, there is no right or wrong answer. I think it's all about bringing all of that together. Michael? Michael? Okay, I think Michael mute አድርጌዋለሁ። Anyway, so Dagi, ተመልሶልሃል ወይስ do you have more questions around that?
ተመልሶልኝ።
Okay. ሌሎቻችሁ ሪፍሌክት የምታደርጉት
ብዙ ጊዜ የሚያጋጥመኝ ነገሮች ነው።
Okay.
ሌሎቹ ነው በኋላ ማለት ነው።
And I thought
Mike.
Jot chal.
Okay.
ወይ ነው
እሺ
በጣም አሪፍ ኢንተረስቲንግ ኮንሴፕት ነው ሁለታችሁ የሚያቀርባችሁት በጣም አመሰግናለሁ። ግን የኔ እንትን ምንድነው ክሊኒካሊ ስትሰራ የሚገጥምህ እና የምታየው ነገር whatever the evidence you have ሰዎች ለምሳሌ አሁን ቅድም በሴሬፓፓዎች ላይ አደልት ከሆኑ በኋላ ኢንተርቪው ሲያደርጋቸው እነሱ የሰጡት ኮንሴፕት እና ቻይልድሁድ ላይ ራሳቸው መወሰን ባይችሉ በፋሚሊ ዲሲሽን ላይ ባለበት ያለ ኮምፕሊትሊ ዲፍረንት መሰለኝ ፋሚሊ ነው በእነሱም ቢያፎ እንትን ዲሳይድ የሚያደርገው ማለት ነው። ለምሳሌ ኤክሰርሳይዝ ብታሰራውና ሌላ ቦታ ቴንስ የሚሰራው ቴንስ የሚደረግለት ከሆነ ወይንም አንተ ኤክሰርሳይዝ ታሰራው ሌላ ቴንስ የሚደረግለት ኢንፍራሬድ ምናምን የሚደረግለት ከሆነ አንተ ኤክሰርሳይዝ ብታሰራ ፋሚሊ ዳዝንት አክሴፕት ኢት ምንድነው የሚለው ሮንግ የሆነ ነገር እየሰራለት ነው የሚለው አይደል? መልቲፕል አፕሮች ተጠቅመ ሰውየውን ለማገዝ ትሞክር ትችላለህ። ግን at the end of the day እንደዚህ አደልት ከሆነ ራሱን ከቻለ ወይንም ቴኑ ትንሽ ቀንሶለት ቴኑ ያለና ቴኑ ቀንሶለት ትንሽ ኢንተርቪው ብታደርገው የሚገኘውን ኤቪደንስ ኤቪደንስ ቤዝድ የምንለውን አውትካሙን አይለውጠውም ወይ? ያን ኤቪደንስ ፉል ነው ለማለትስ እንትን አይለንም ወይ የሚል ጥያቄ ስላለኝ እስቲ ይላል።
Yeah, I think Zalalam can reflect on this. Very interesting. I completely agree with Mike on the questions.
Can you summarize it?
So ለምሳሌ አሁን ፔሸንቱን አሁን ለምሳሌ እነኚህ after years of እንትን አይደለ ኢንተርቪው ሲደረጉ ያው ሲያስቡት ኦኬ ሜቢ እንደፈለጉ ወክ ሳያደርጉ ቀርቶ ስለሆነ ሊሆን ይችላል። ኢሚዲየትሊ በዛ ሰዓት ግን ኬሩ በተሰጣቸው ጊዜ ኢንተርቪው ቢደረጉ የሚሰጡት መልስ ሌላ ሊሆን ይችላል። ፕላስ ደግሞ ህፃናት ስለነበሩ ፋሚሊ ደግሞ የሚወስነው ነገር አለ አይደለ? ፋሚሊው ይዞ የሚመጣ የራሱ የሆነ ባያዝ አለው። ፕላስ ደግሞ ኒድ አለ፣ የፋሚሊ ኒድ አለ እና እሱን እንዴት ነው ባላንስ ማድረግ የምንችለው ነው? I think it's really interesting practical question I believe.
I think እዚህ ጋር ቻሌንጂንግ ግን ምንድነው ኤቪደንስ ቤዝድ ፕራክቲስ በጣም ኪው አንዱ ኪ አስፔክቱ ምንድነው ኢንፎርምድ ኮንሰንት ነው አይደል? ስለዚህ ኢንፎርምድ ኮንሰንት ስንል እንደ ቴራፒስት we have obligation ትሪትመንቱን በትክክል ማወቅ አለብን። ኤቪደንሱ ከረንት ኤቪደንሱ ምንድነው የሚለው ስለዚህ ይሄ ትሪትመንት ይሄ ነው ኢፌክቱ ይሄ ደግሞ ይሄ ነው ኦልተርኔቲቭ ይሄ ነው። ስለዚህ ቹዝ the patients can choose by themselves። ስለዚህ ኢንፎርምድ ኮንሰንት በደንብ ያስፈልጋል። አለበለዚያ it's not right። ስለዚህ ለምሳሌ አንዳንድ ኢንተርቬንሽኖች we know they are short term outcome አላቸው ያሳያል ኤቪደንሱ ፔሸንቶቹ ነግራቸዋለን this is the effect the alternative ይሄ ነው። So I think that's what we have to do, but we don't do that. Informed consent is not very common in the aspect of the evidence-based practice. Key aspect.
I think that's why evidence-based practice is challenging. In theory, on paper, it looks good. It seems feasible. It seems doable. Again, in practice, it's very hard. ለምሳሌ patient በጣም ሲቪየር ፔን ኖሮት መጥቶ አልጋ ላይ አስተኝተው ልጄ እየተሯሯጠች ነውና ድምጽ ከሰማችሁ I cannot do anything about that. And so አልጋ ላይ አስተኝተው ፔሸንቱ የሱ ፕሪፈረንስ ሌላ ሊሆን ይችላል። ስለዚህ how do you balance that? It's hard አይደለ? በዛ ሰዓት ስለ ፔን ኤጁኬሽን ብታወራው ትርጉም ላይ ገባ ይችላል። Maybe the immediate thing is to reduce pain, to reduce suffering, and then to work with the patient towards a long-term goal, which is really based on function and patient's participation in life, and so. But obviously, it's a challenging concept to put it in practice. Sisai?
one question I just add some points. The good thing currently we are integrating the evidence-based practice module into the current curriculum, so our students already started early in their second year courses, so they can have the knowledge about how to access those data and how they can use in a different clinical setup. Maybe the problem we are not using those evidences, the level of the emotional attachment, and so ብዙ ጊዜ maybe they can see people በዛ እንትን improve ሆኖ ሊሆን ይችላል። we always look some of our patients improvementቸው በምንድን ነው የሚለውን ግን we don't ብዙ ጊዜ measure አናደርገውም። objectively we cannot measure our patients improvement ብዙ ጊዜ እንትን አናደርግም especially the clinical setup ማለት ነውና maybe this can be because of the patient and therapist ratio ሊሆን ይችላል ያለብን ፔሸንት ቁጥራቸው አለመመጣጠን ሊሆን ይችላል። ሌላ the accessውን ለመጠቀም ብዙዎቻችን maybe ብንጠይቅ ብዙ ሰው ይሄንን አርቲክል ማግኘት አልቻልኩም ምናምን ይላል። የሰርቺንግ strategy is weak. Most of us we didn't know where we got those evidences and we didn't know how to search. The lake ካነሳቸው concept there are two types of background and foreground questions. ብዙዎቻችን background question simply google ላይ search የምናደርገውን የሰርቺንግ strategy ነው የምንጠቀመው and we didn't know where we find especially ብዙዎቻችን ፔድሮን or PubMed Google Scholar የሚለውን access ለማድረግ almost most of the clinicians and ያንን እንትን access ማድረግ ትንሽ shortage አለ ብዬ አስባለሁ። ሌላ like outcome tool የመጠቀም ፕራክቲሳችን is less። እኔ በጣም ብዙ ጊዜ ማስተውለው ነገርና ከክሊኒካል ጓደኞቼ ጋር ማወራው most of them simple outcome measures like የፔሸንቱን ፔን ምናምን የተለመዱ like VAS pain rating scale እነዚህን የፔሸንቱን functional እንትን measure የሚያደርጉ outcome measureዎች አለመጠቀማችን that make the intervention እንትን ወይንም ቫልዩን የትሪትመንት ሴሽኑን በደንብ ኢቫሉዌት እንዳናደርግ የሚያስቸግረን ነገር ነውና እነዚህ ነገሮች ቢታከሉበት እንደ there are different the critical appraisal menu different tools አሉ እነሱን maybe next time menu trading cover የሚደረጉበት maybe like Perro JBI different types of research የምንጠቀማቸው ቱሎች ደግሞ next time provide ቢደረግ it's good ብዬ አስባለሁ thank you.
Thank you, Sisa. I think it's an absolute summary of our discussion, and I really loved all of the points you raised, particularly around like integrating evidence-based practice into curriculum and teaching students early on while they are at school is very important. ምንም ጥያቄ የለውም። ከዛ በኋላ ደግሞ ያነሳቸው እነኚህ አውትካም ቱል መጠቀም ፕላስ ደግሞ እንዴት ሰርች እንደምናደርግ እንዴት እንደምንጠቀም አለማወቅ it's a very common issue I think in Ethiopia now. Obviously I think I know EPTA ሰዎች በጣም እየሰሩ ነው for sure ይሄንን at the end of the day it's all about enhancing capacity of physios to practice physiotherapy safely in Ethiopia but also based on evidence. ስለዚህ በአንድ ቀን የሚመጣው ኮንሰፕት ላይሆን ይችላል it will take years as the profession grows. ያው ቀደም ስናይ ነበር አይደለ ለምሳሌ እንግዲህ the French army ሲጠቀሙ የነበረው active physiotherapy ብሎ ያስቀመጡት አለ at least እንግዲህ አንድ ሴንቸሪ እና ከዛ በላይ የቆየ ቴክኒክ ግን ምን ያክል ወደፊት እንደወሰዱት ማሰብ እንችላለን እና እኛም ገና we are new players in this profession አይደለ in Ethiopia we are still young the profession is young again we are expected to do a lot schools obviously must do a lot to equip the students with I think evidence-based practice skills but also I think ከወጣን በኋላ continuous professional development ላይ engage ማድረግ ፕሮፌሽኑን ማሳደግ ዩኒቨርሲቲዎች ለምሳሌ ወይ ደግሞ ኢንስቲትዩሽኖች እንዲያድጉ ካረግን ኤቪደንስም አርቲክሎችንም እንዲያገኙ ሊያደርጉ ይችላሉና I think we have a lot to do. We have a lot of assignments and homework in front of us but thank you Sisai for the summary. We have 6 minutes and so ሌላ ጥያቄ ኑርልኝ ይሰማል
እሺ በጣም እናመሰግናለን ዶክተር ሙልጌታ እና ዘላለም ያቀረባችሁ ፊቱ በጣም አሪፍ ነበረ በዚህ በቃል ብዬን ማላምንም ወደፊት ይሄ ጅማሩ ነው ኖርማሊ በአንድ ላይ እንደዚህ ዲስከስ ማድረግ ያስፈልገናል እናምናለን ብዙ ፕላንም ይዘናል ወደፊት እንደዚህ በሳብጀክት ማተሮች ላይ ዲስከስ እናደርጋለን ፕላዛስ ደግሞ እንደ ፓናል ዲስከሽን እንደ ሙያ ታውቃላችሁ በሀገራችን ውስጥ እንጭጭ ሙያ ነው ገና ብዙ ቻሌንጆች አሉ በመንሰራባቸው ኢንቫይሮንመንቶች በመንግስት መስሪያ ቤቶች አካባቢ ከማልፕራክቲስ አንጻር ብዙ ችግሮችም ስላሉ ከሜምበርም ጋር አሁን ዛሬ 34 አካባቢ ላይ ቀላል ነገር አይደለም ዌቢናር ላይ ተጠርቶ በሾርት ኖት ያው አንድ ቀን ምናምን አስተውቀን 34 ምናምን ደርሶ ይቻላል ቅድም ያ ማለት በደንብ ብንሰራ አብረን ዲስከስ ብናደርግ የተለያዩ ሾዎችን እንደዚህ ኬዞችን ብቻ ሳይሆን እንዳልኳችሁ የሙያው በአገር ደረጃ ያሉበትን ቻሌንጆች ብቻ አይደሉም እንደ ሙያ ማደግም ስላለብን እንዴት ማደግ እንዳለብን የምናዘጋጃቸው የፓናል ዲስከሽኖችም ይኖሩናል ትሬኒንጉም ይቀጥላል ለዛሬ ያቀረባችሁ በጣም አሪፍ ነገር ነበረ ቴንኪው ለማለት ነው አመሰግናለሁ
Thank you, Nurulin. I think that's great. Yeah, I know ለዛ ነው I think continuous ስራዎች እንዳሉ ማቃለው በደንብ መቀጠል አለባቸው በደንብ ሙያውን ለማሳደግ ፕላስ ደግሞ ሙያው ሲያድግ ነው ኢቨን ክሊኒሻኖቹን ፊዚዮቴራፒስቶቹን ተጠያቂ ማድረግ የምንችለው አይደለ ላይክ ሙያው በደንብ ሲያድግ ያንን ካፓሲቲ ዴቨሎፕ ስናደርግላቸው ቱሎችን ሰተናቸው ኢንቫይሮንመንቱን ፌቨራብል አድርገንላቸው ያኔ ተጠያቂ ልናደርግ እንችላለን where is your evidence ብለን ሬጉሌትድም ስለሆነ ሙያችን በዛ መልኩ ተጠያቂ የምናደርግበት ጊዜ ይመጣል obviously ወደፊት እንደዛ ነው የሚሆነው ግን in the meantime ግን we have to do a lot አሁን we are in the wilderness of exploration ስለዚህ I think we need to obviously work together as a team and now hopefully we will grow together in the future እንግዲህ ሌላ ጥያቄ ካለ I think መውሰድ እንችላለን otherwise if anyone wants to have concluding remarks or I don't know talk
ብሩክ ምናልባት ብሩክ
እሺ ዘሌ ሙሌ በጣም ነው የምናመሰግነው። ያው ሁሉንም ፎሎ እያደረግነው ነበረ። ፐርሰናሊ በጣም ጠቃሚ ሆኖ አግኝቼዋለሁ። ያው እነኚህ ትሬኒንጎች ኦልሬዲ ፕሮሚስ እንደገባችሁልን ከዚሁ ጋር ተያይዞ ያሉትም ሌሎች ተከታታይ የሆነ የኦንላይን ትሬኒንግ እዛ ላይ ሄልፕ የሚያደርጉልን ሰዎችም ሞቢላይዝ በማድረግ እሱ ላይም አክቲቭሊ እንድታግዙን እንፈልጋለን። የዛሬውን ኦልሬዲ ሬጂስተር ያደረጉ ሰዎች ላይክ ለ90% ያህል ኦልሬዲ አቴንድ አድርጓል። ለቀሩትም ግን መልእክቱን ሼር እንድናደርጋቸው መጀመሪያ ዲስከስ እንዳደረግ ነው ፓወርፖይንቱ እና የኦዲዮ ሪካርዲንጎቹ እነሱን ድሮፕ አድርጉልን። ስለዚህ በዚህ አይነት ፕላትፎርም እንደምንገናኝ ተስፋ እናደርጋለን። ያው ለዛሬው በሾርት ኖቲስ ለሰጣችሁን ትሬኒንግ በጣም እናመሰግናለን። በይብታስም ቴንክ ዩ ቬሪ ማች
Thank you so much.
Thank you so much. እና መልካም ቅዳሜ ከሰዓት ይሁንላችሁ። እንግዲህ እኔ ገና ቡና አልጠጣውም ሰው መልካም ቀን። ፓወርፖይንቱን እና ሪኮርዲንግ እንልክላችኋለን በእነ ብሩክ በኩል ይመጣላችኋል።
Great.
Thank you. መልካም ቀን።
ለሁላችንም
ቻው።
ዛሬ ደውል
እሺ